I started working in this specific area in breast cancer because of a personal tragedy. And this was about, I want to say about 8-9 years ago. And we've been working on, I've been working on some different aspects of breast cancer detection and diagnosis. As you all know, or may know, just a second, let me see if this is the right one. Yeah, so breast cancer is a big killer. You know, the average American woman has a 1 in 8 chance of having breast cancer. I'm assuming you can see my slides. Yeah. And you know, there are 40,000 women who die of breast cancer every year. Now, because of this COVID crisis, for example, right now, it's taken us many years to bring down the fatality rate in the United States. And it's been persistent at this level of 40,000. It hasn't really gone down much beyond that. It used to be much higher. They're projecting that next year, this number will be at least 10% higher, because a lot of women have not gone for regular screening, have not gone and gotten necessary care.
Interesting.
And so in just 1 year, we have probably lost about 10-15 years of progress.
Hold on now, I understand the notion of women didn't get checked this year, something went undetected, they died the next year, that's why you expect it. But why do you say we've lost 10 to 15 years worth of progress? I don't understand.
Because it took 10 to 15 years to get the mortality or the fatality rate from breast cancer from something like 55 or 50,000 down to 40,000.
I see.
It's not just the mammography, it's not just the screening, it's kind of getting people used to the idea, getting women into, you know, it's kind of like, you know, yeah, we have a vaccine, but now we've got to make people take the vaccine.
Mm-hmm.
So it's the same thing. It was education. It was you know.
Do you believe it ruptured the flow of people going for their annual checkup?
It essentially stopped it.
I see. It is. Is it an annual thing, ladies on the call?
It is depending on the some of the agencies. For example, ACR, the American College of Radiology, says it should be annual. AHRQ says it should be every 2 years, but it has to be a routine screening after the age of 40.
The device we're seeing on here is yours?
No, this is a standard mammography device. Our device, so we're a development stage company. We do not have a device at this point. We're working on one. We're in research and development right now. This is a state-of-the-art device from one of the leading manufacturers. I believe it's a Hologic device. And I just put it up here to show you what it looks like. This is what a mammography system, most women are used to seeing these and have been tested by one of these. Because regular screening with mammography is the only approved imaging test that has been shown to reduce deaths due to breast cancer. It's the frontline method. It is the gold standard for breast cancer screening. And it has been credited with bringing down mortality. But there's a problem. And the problem is what's known as breast density. So mammography fails women with what's known as a BI-RADS-C or higher. I'm kind of getting a little bit into the weeds, and this is 40 to 50% of women. It is much higher in certain other populations. For example, among Asian women, it could be as high as 70%. These are women where the breast density makes it hard to find a breast cancer on a mammogram. Mammography is perhaps the most challenging areas of radiology. Finding breast cancer on a mammogram for a radiologist is like finding a snowball in a snowstorm. It's very difficult to find it. You have to. And so for, you know, like you break a bone, you go to radiology, you see a fracture, you have a problem with arthritis or something like that. You can see it very clearly. Here, it's very difficult because you're trying to discern one type of soft tissue from another. And so that's why breast density hides breast cancer. It's this masking effect. But then there's another problem. Women with higher breast density are also have been shown in many studies now to have a 4 to 6 times higher risk for breast cancer than women with lower breast density. And so it makes it all the more important to find a solution for these women. And that is the reason why we exist. That is the reason for our work at Fischer.
This is just so ignorant of me, but I'll ask. Does a woman, I feel so stupid, I'm just a man and I don't know these things. Does a woman typically know how dense her breast is if you look at this kind of level?
Just palpation, by touching your breast or age, for example, is a big indicator. It's not necessarily the case. Young women have dense breasts. See, less than 40, I think it's 80% of women less than 40, not all, have dense breast tissue. But actually, this is one of the outcomes of a mammography exam. A mammography exam basically tells you two pieces of information. The first piece of information is, do you have dense breast tissue? And then the second is, what is your risk of breast cancer? This is the two things that a radiologist will tell you in their report. Now, if the answer to the first question is you have dense breast tissue, they are by law now, 38 states, in I think last year, the federal government enacted legislation that requires a doctor to tell you that because the answer to the first question was yes, the answer to the second question can no longer be trusted. And as a result, you have to go and get supplemental screening. So this is just as an introduction, this is what the situation is. And
that's what your second chart there is with the pink?
Those are the 38 states.
So those 38 states say, hey, look, I learned that you have dense breasts and therefore take what I'm about to tell you directionally, but you need more testing?
Well, they will tell you that you need to either go get an MRI or get an ultrasound or some other test.
I see.
Or in some cases, just get a biopsy.
Okay.
So Fischer Imaging has been working in this area for a few years now. I started with Fischer about 4 years ago, which is about the time I met you, Joe. We have two product traction or strategies, if you will, MammoCat and MammoSound. The first is to improve the performance of today's mammography. Today's mammography does not have the needed resolution or the needed contrast to find that snowball in a snowstorm. It's really hard for the radiologist, based on today's technology, to get that job done. And we believe that we have a solution for that, and that we've been working on that. And then we've also been working on the combination of mammography with one of the most popular, the most commonly prescribed supplemental tests for women with dense breast tissue, which is ultrasound. So it's basically a two-for. We get both tests done in one system, and I'll go a little bit more deeper into that. Just a little bit about the company. Fischer has been a pioneer in breast cancer care. A lot of the technologies that are out there today that are used by companies like GE, Siemens, and Hologic were at some point or another pioneered by Fischer. This includes digital mammography or mammography guided stereotactic biopsy. And there are these mammotest tables, these are biopsy tables that were sold by Fischer back whenever, this was before my time, that are still being used. We, at this point in time, are essentially a startup mode because all of those technologies were sold off. And we have some intellectual property and some technology that we're working on, which we believe is going to help improve the performance of today's mammography. So I just wanted to tell you a little bit. I don't know if this will work. If it doesn't, I have a backup. This is our MammoCat technology for improving the performance of today's mammography. Let's see if it works. If you cannot hear, let me know. You cannot hear it? Okay. So.
Which is why, as your marketing friend, I tell you always to put captions on your videos.
Okay, thank you.
You're welcome. Can't help myself. You're not sharing anything, by the way.
I'm going to, I have another slide that I can just show, and then I'll just explain it. So this is can you see my slide?
No.
Should I share screen? There we go. There we go. Can you see it now?
Yes.
Good. So this is just a little cartoon to show what we're doing. So the picture on the left shows mammography as it's practiced today. The breast is compressed within between two parallel surfaces or plates. The bottom plate has a X-ray detector, and a cone beam of X-ray, as pictured here, is used to irradiate the breast, and the shadow of that X-ray image is captured on this large two-dimensional detector. Most women are familiar with this process. It's painful, it's uncomfortable, but more importantly, because of this cone beam radiation, there's a lot of scattered radiation that is caused in the process of getting this shadow. In fact, the majority of the radiation that reaches that detector is what's known as scattered radiation, which has no information, and it actually adds to the cloud or more of the snow in the snowstorm. Now, they use what's known as a grid to get rid of some of that scattered radiation, and unfortunately, that also tends to add to increased dose, which is another big concern when you're using X-rays. You don't want to cause cancer while it's trying to detect it. Let's see. So the picture on the right is our technology. We use what's known as a fan beam, a very thin, almost paper thin beam of X-ray radiation to scan the breast, as shown, in precise alignment with a very narrow line-shaped detector. So it's no longer a large piece of silicon, it's a very thin detector. And because the scattered radiation is now only limited to that very narrow paper thin surface, if you will, we essentially get rid of all of that scattered radiation. And as a result, the resolution and the contrast of these images is significantly improved. We've shown about a 30 to 50% improvement in resolution and contrast. And we do all of this without having to use a scatter removal grid. And as a result, our dose is about half the dose of today's mammography. You also notice that we can use a more painless configuration, not this painful flat compression, because we can change the exposure setting as we scan the breast from the chest wall to the nipple. And so that is not something that is possible with today's technology because it's just a one shot.
Please don't advance your slide. I'd like to ask the group if they feel as though they understand the essence of what Shabbir just shared. And I'm asking that because I directionally do, but I feel it probably could have been clearer. And because this session is about helping you
Articulate this better, yes.
Andre says that he understood it and it was well explained. And John raises his hand. So let's see. Michelle says, yeah, so that kind of, okay, everyone's following. Yep, I'm getting yes, 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 and yes.
Thank you, guys. And you know, that's why I had the video, but this was my backup. But just to, let's see if I can go back. I'm having some trouble. So going back to the slide, as I said, we get higher resolution, higher contrast, low dose. How do we know that? Well, we use what are known as these breast phantoms. These are the same type of testing devices or testing methods that are used for doing quality control, quality assurance on existing mammography systems. The regulations require them to test their systems on a periodic basis. So we're using exactly those same phantoms. These have these embedded mimics of shall we say, cancer. Mammography basically looks for what are known as microcalcifications and masses. And so this phantom has both of those embedded in them. And so, for example, what we have done is looked at some of the most challenging masses. These are very thin inserts inside this material that mimics breast tissue.
What is this on the right, CIRS?
That's the breast phantom on the right, the actual product, and this is a map of what's inside it on the left.
I see. And this device is used as part of what
quality control on mammography systems to test how good they are.
Across brands and platforms.
across brands and drugs, exactly.
Thank you. Please continue.
And this is what, for example, the FDA requires any manufacturer who wants their product to be approved to show their performance on. Okay. And so I've highlighted those challenging masses, which are very difficult to see. And so, for example, here is a picture of exactly those taken with a state-of-the-art mammography system, a hologic device, which we have in our clinic, and compared that to the performance we've gotten with our prototype device in our lab. And as you can see, those are very difficult. That's the snowball in the snowstorm that I'm talking about. They're very difficult to see. If those were actual cancers, it's a real challenge for radiologists to find them. And we, I'm not going to go into any detail on that, but we've shown a 30 to 40% improvement in contrast as we've calculated based on these dose-matched, technique-matched image sets. Everything the same between the two devices and the same phantom, but here to kind of show to you what improvement we're talking about, here it is. I'll pause if there are any questions.
Please continue.
We have been fortunate to have very good partners in our work. We've received multiple grants from the National Institutes of Health, in addition to other support and advice. Our development partner is Johns Hopkins, and we require these specialized detectors. And so we're very fortunate to have support on that as well. And our technology is patented in the US and Europe, and we have additional applications in process. So this is basically our MammoCat technology. And then I want to talk just briefly about the next product that we're working on, which is MammoSound, which is to combine the most popular supplemental screening method or modality with mammography. Now, there is...
Let me ask, because you shared at the beginning, you have MammoCat and MammoSound.
Yes.
And you are in development, and I suspect one will come before the other.
Correct.
Perhaps to make the best use of our time, should we focus on the one you wish to launch first?
Well, this is the one we wish to launch first. I just have a couple of slides on this.
By all means, I just wanted to...
Yeah. So MammoSound, basically what it does is it takes the two best breast cancer screening modalities and it combines them into one device. And the reason for that will become obvious as I talk to you. What happens today is a woman goes in and gets a mammogram, and the doctor says, look, you have dense breast tissue, you need to go get this other supplemental screening. And so most popular method is this handheld ultrasound mammography, if you will, or ultrasound scanning that is done. As we've seen with the COVID pandemic and the lack of resources and whatnot, it's become very difficult to find the skilled resources to do the handheld ultrasound in person. It was always there, it's become even worse. So people have been working on what's known as automated breast ultrasound, which is what is pictured there at the bottom. And that basically takes away the human factor or the skilled human factor to some extent and allows the ultrasound scanning to be done in an automated fashion. Whereas you see those two procedures are done with the patient in a very different configuration. One is upright and the other is supine. And so now taking those images and trying to compare those two becomes a huge challenge for radiologists. What we're doing is we're combining both modalities in the same patient configuration, in the same time, and on the same device. And we believe that that will improve clinical workflow, patient experience, and reduce the number of errors. And so that's the other product that we're working on. Here's a kind of a statement from one of the leaders in the field, Dan Kopans at Harvard Medical. And he says, it's about time. I've been trying to get companies to put ultrasound into mammography units for at least 25 years. We worked on prototypes years ago. Both GE and Siemens have developed, but they never pushed them. And I suspect it was because they were making more money selling two separate units instead of a combined system. Just something to think about. Well, we started getting our first images, and this is the first time that people have actually been able to look at a mammography image on the left with a reconstructed ultrasound image on the right. And now, because you have them both in the same configuration, with the patient in the same position and in approximately the same visit, or the same amount of time, of course, in the same visit, you can now use these two images to do a better job. Opens up the opportunity for doing artificial intelligence, for image comparison, all kinds of other advanced techniques. And I think that's it. Here's my team. This is a lot of folks have been involved in this, and we couldn't have done this without people's help. Alan is our Chief Operating Officer. Samir is our CTO. We bring a lot of experience in the medical imaging and diagnostics arena with this team. Just a little bit about the market. I don't want to go too much into it, but this is a significant opportunity for our company. More importantly, we believe that it'll help reduce that number of 40,000 significantly. And again, thank you for your attention.
Why don't we not share slides anymore, just have us talk.
Sure.
And let me ask you to identify your top 3 issues keeping you between where we are today and your successful commercialization.
Well, of course, the biggest issue is going to be funding to be able to take this. We're not actively looking for money right now. We're focused on getting us to a point where we can have what we call a clinical prototype, and we have the funds to do that. It's just the time that is going to take. COVID really hurt us because our labs were shut down for about 6 months. So that, delayed things. We should have been much further along in our development. So that's number 1. Number 2 is, sorry?
You showed 3 people on your slide as being part of the team. These developers, where are they located? Do you have sufficient? Are we talking the design stage? Because we have folks from all walks of life on the call. So if I magically just waved my hand and said, here, my small army is here to help, what would you have people do?
Oh, I see.
There,
okay.
you do that. I need this.
Yeah. We need help with this what we call systems engineering, with putting things together. We believe we've shown the basic feasibility of the technology, but there's a big chasm to go from there to an actual clinical prototype. Okay. So if there are folks out there who know how we can get from where we are, what we essentially have, the images that you saw, are images that we have captured with a lab. It doesn't look like a mammography system. It looks like something that some engineers put together on a workbench. We need to take it from there to a product, such as
for someone to raise their hand here that I can.
Sorry?
I'm looking for folks on the call to raise their hand if they have something to add or talk about there. Tell us about something else that you.
So the other thing, of course, is we will once we're ready to with our clinical prototype, we will need help with the regulatory aspects of this to do our regulatory filing. And then finally, the whole commercialization. This is not something that we have the team has some expertise in this, Alan does, but this is a different area. This is large capital equipment, people with experience in commercializing and launching large capital equipment of this nature. This is an area that is very, there are large corporations, the big guys are there, they're aggressive, they're pushing their own technology, and this technology basically turns all of what they're doing on its head. It takes people in a different direction. And just to give you one example, this industry is going towards what's known as tomosynthesis or 3D mammography, which hasn't shown value, but because of the millions of dollars that are spent pushing it, has been adopted. And it's really hard to kind of tell them, well, hold on, look at something else. And so that's not something that we're looking forward to, fighting that battle, but we will have to.
Michelle, you sent me a note. You're on another call at the same time, so you can't speak right now. Yes or no? You're on mute here, so. Okay, she might be multitasking. Mark, you were first. You are on mute.
Hello, Dr. Bambot. Really great talk. So I've been involved in breast imaging for the last 30 years. I've worked with QT Ultrasound, with Cape Ray Medical, which also, are you familiar with Cape Ray?
I do. They're the South African company, right?
Yeah. So I know the CTO kit pretty well. And so where are you physically located?
The company is located in Denver, Colorado, just outside Denver. Right now, I'm physically located in Los Angeles.
Okay, cool.
But we have a distributed team right now.
Yeah. So we should probably talk offline. I can help. I know a lot about this specifically and launching capital equipment in general. But one question I had, so Fischer Medical, who I used to work with, maybe it's a different, it sounds like you're not Fischer Medical, you're using their, and you're kind of integrating.
We used to be part of Fischer Medical, but we split last year.
And whose ultrasound are you using?
We're using a couple of different ultrasounds. We're using a Siemens ultrasound, and we also use an ultrasound by a company called Clarius.
I know Clarius and Siemens well.
Yeah.
Okay, we'll talk offline, but this is interesting. I'd love to help you out.
Thank you.
Dwayne.
Yeah, I just wanted to pop into, and we could take this offline, but when it comes to your clinical strategy and execution, this is something that fits into Covance's wheelhouse. So this is our second most popular therapeutic area. We're running 2 other trials that are just in my territory alone that are similar, that are in this space. So we have a lot of connections to be able to get this up and running quickly. So yeah, when the time is right, I know that's a long way off, but when you start having those discussions of the strategy and design, we can help. We can help with regulatory as well. But I'm thinking that's what Michelle is on the line for as well. So.
Michelle, I was going to pick you back as an attendee if you're not able to.
I just got off, so I had gotten a call during that. So if you could give me like a 30-second catch up.
The 30-second catch up is, I think, unnecessary, actually, because the question I have for you is, I know that oftentimes folks don't, and I'm not saying this is the case with Shabbir, but oftentimes folks don't necessarily start thinking about regulatory strategy until they're further along the line, and they're like, oh, now we have to think about submission. Is there some basic framework or template or something that we can do a checklist to make sure that Shabbir is already kind of thinking the right way?
Yeah, so I start all my projects with what I call the regulatory pathway assessment. And ideally, I start them at very early concept development. So sometimes even before they have all of their technological features decided on. But knowing what the requirements are in advance helps inform those decisions. It helps inform your testing, your acceptance criteria. Like sometimes people might want to try some maybe novel material or maybe a novel way to deliver radiation. And then, but knowing the set of expectations you're going into from the start helps inform those decisions and how challenging it's going to be to bring that new technology to market.
Shabbir, tell me, has this been part of your process to date, thinking about the types of things that Michelle just raised?
So I'm not sure. I'll admit that it's not like we've done a full-up regulatory strategy or regulatory pathway analysis. We've done what I would call a poor man's regulatory pathway analysis. We do have guidance documents from the FDA. This is an area that the FDA has been fairly clear about what they expect of new manufacturers in the space. So for example, for a mammography system, such as the one that we're talking about, it's a 510K, and they would need the kind of images and testing and safety stuff that is done using essentially phantoms. They do require a very small human factor study, I think about 6 or 7 subjects, but that's pretty much it. For the ultrasound, there is going to be somewhat more, because now we're not just following a beaten path where this is new territory. There's no product out there that we can say, okay, this is the predicate. So there we still need to do some more work. But I accept what Michelle is saying, and I understand, and maybe this is something that we can connect in the future about.
Well, that's the point of this call, to pair you with some resources you might not have been aware of or known that you needed. I had a private comment here from a member saying that this member was familiar with the company. He's talked with the company in the past, and I know this part of the history, that there have been management changes and starts and stops, and he speculates that that might prove to be challenging for you in your story when it comes time to get people to buy in, believe this time we're really raising money and the like. Is that your experience, and what would you tell this member?
So that has not been our experience, but I can see the point, and it very well might. Fischer Imaging right now is free and clear, wholly privately owned. We're going forward with intellectual property that has been vetted. We own it, again, free and clear. So there's no issues there. We're here to address a problem that exists, and that is not being addressed today. And we have unique proprietary technology that will help us get there. I don't know what else I can say about that, except what I just did. If folks think, well, Fischer Imaging is the very fact that you have the name Fischer Imaging is a problem. I don't know how to address that, except that, the name is recognized in the industry. People respect it. There are products out there that people love and continue to use through support from third-party service providers. And when we go out to sell this device, we don't have to say we're with Acme. Who are you? When you say Fischer, people know who you are.
Are you using any technology that originates from the mother Fischer company?
Yes, we are. We purchased that technology. So that technology is in the form of patents.
Okay. So yeah, like you said, it's nice that you have that, and it's in your it's in your domain, it's yours. But I think this will still be something to consider from a freedom to operate perspective.
Yes.
Like you said, especially in some ways, it's easy because you know who the big players are, right? But they're like you also said, they're very big players with unlimited pockets. So infringement will be something you have to consider early as possible before
Correct.
Maybe you start assembling everything, and while you still have time to tweak the design. And especially being that it's two different technologies that you're merging, either one of those technologies separately, you could be infringing on. So you might have the IP for the combination, but if they have IP separately on small elements of either one of those technologies, you have to make sure you're not infringing, because it's a high likelihood that they will get into litigation. They don't have a problem with that.
Here, I know you have patents. We call Andrea the patent detective because she's going to find something. You might want to follow up with her as well.
I would love to. Yeah. Thank you, Andrea.
You're
and I think your comments are well taken. I completely agree with you. We've, in my life and my previous work, we've had exactly these issues. People come out of the woodwork as soon as you're successful. And our strategy, though, is not to necessarily, kind of snub people in their noses or anything like that. If somebody has, like, for example, the ability to take the images and put them in a PAC system, there's so many technologies out there. We would rather license some of that. We don't want to necessarily reinvent that field. This is not our core expertise. So rather than fight somebody or stomp somebody's toes, we'd rather just license that technology and pay them for it.
Right. You just
reach
need
an
to
agreement.
you just need to know that early on, right? You
Yes,
don't want to
yes.
work on it and spend your time and capital on developing the system, not knowing that it already is developed, at least from a theoretical perspective, right? It might not be a
Sure.
product, it might not be something out on the market, but in theory, it could have already been described and protected.
Thank you.
Thank you, Andrea. Sue, you had a comment? You are on mute.
Yes, there's a company called Deep Look. I don't know if you've ever heard of them. I think they're out of Boston, but I was in an incubator accelerator program with them down at Inova Fairfax in Northern Virginia. And what they're doing is they're advancing the medical imaging by providing vivid color imaging from the underlining morphology from the regular black and white imaging. And you can, you know, I remember seeing some of the slides and how vivid you could see the tumors versus the black and white imaging, which you couldn't see at all in dense tissues. I didn't know if you spoken to them, if you knew about them, and you may want to contact them.
I've known about them. I know about them. I have not spoken to them. I've not followed them recently. You know, basically what you're talking about is image augmentation with some kind of color or other means. And we would like to do something like that. The problem we realize, and I think this might go into some of Andrea's comments, is I want to do all kinds of fancy things, but I'm going to be slapped by the FDA. And they're going to say, yeah, well, now you want to do image augmentation, show us a 500 subject study that shows it works. And we're a small company and we just cannot afford it. And until we get there, that's fine. But we have to be able to support that. But I'm happy to, I mean, if these guys have technology that has been vetted, that has been shown to, has some kind of, regulatory track, then I'm happy to talk to them.
Yeah, I think it would be a good connection for you to make, and possibly you could work together. They're called Deep Look, and I can certainly send you the email or information.
Thank you, Sue. Really appreciate that.
Well, that's why we do these calls. I love when the team comes together to help a member. So thank you, ladies. Shabbir, one of the things we talked about a while ago, and it's still, as a strategist and someone who helps with commercialization and the like, I'm still concerned about your competition, and that even if you come to market on time, on plan, budget, we're excited, we're going, the competitive response can be fierce and drown you with money and time and effort to say, why would you do that when you have this, and not to mention contracts and the like. It's been a while since we've spoken at length about that. What progress, if any, have you made on that? Are you talking with potential strategic partners? Are you looking to potentially get the technology to a point where you're just acquired, or are you looking to necessarily get to market under your own brand and try to market against the industry leaders?
It's a tough one, Joe. I mean, there's no sugarcoating that. That's a tough issue. I and my team did not get into this just because we thought, oh, this is something to keep us busy with and a nice project to do. As I said at the beginning of my call, I got into this because of personal tragedy. And we're very focused on this. We know that there is, shall we say, the best way I can say that it's unfair. There's unfair business practices going on in this area, which are preventing patients from getting the best care they can.
Mm-hmm.
And we want to change that. Now, speaking about Fischer, for example, for a minute, Fischer actually sold a lot of technology to some of the big players out there. Some of that technology would have actually improved care, but was buried. I do not want to get into a situation where we develop something only to be buried because people are making more money selling today's technology. That's not what I'm doing this for. So if we can get to a point where we can actually show that, and we're kind of at a better negotiating position, where what we develop will actually end up in the marketplace and will actually end up saving lives, we're happy to partner. We're happy to be acquired.
Andrea, I brought you back because he brings up this buried concept. I imagine there's a lot buried. And the fact that Shabbir has firsthand knowledge of the good stuff that went somewhere else. I mean, Shabbir, are you trying to figure out, given the parameters of what was sold, I know I can't do it exactly this way. So if I can find another way around doing the same thing, let's try to do that. Is that what you're working on? And how fraught with risk, Andrea, is that, approach?
Yeah.
When you're talking about big boys, right? Like these competitors, and it's nothing unusual in any technology, right? Whether it's breast imaging, medical or non-medical. This is just normal practices. They want to protect their yard, right, and enlarge it, and so they're going to do anything possible, and it's a business. So even though it's not for the patient's best interest in mind, and I'm sure this has happened, and there is that's why in some ways patents are a way of discovering that kind of stuff, because as long as it has not been secretly protected, the patent applications at some point will come to light. And unfortunately, the licensing and mergers and acquisitions kind of information is not widely available. So we might not see who the current, so once somebody buys something, they don't have a duty to report that to the patent office that, oh, this IP now belongs to somebody new. So that
you can discover it though.
We can discover the IP, and then it might take some detective work to see who actually owns it.
You are the detective.
I am, but there's no laws that require people, right, to disclose that information.
There's no reporting
knowing
obligation.
that the IP is out there, I mean, there's lots of things you can do to track down who the ultimate owner is.
We're playful, and I know that we're kind of building a brand around this concept of detective, but if we need to detect this and you are the patent detective, can you confidently say, I can detect it? I don't know what's involved in it beyond the kind of concept. Can you find out because that's what you do? Or no, they can really bury it and even I can't find out.
Yeah, they can. I think that there are ways for them to bury it using third parties that buy it on behalf of somebody else. So there are ways where not even I can figure out that information.
Not even you, it cannot be done.
Yeah.
Okay. Thank you.
Yeah, there's lots of sneaky ways. However, there's a lot you can do where, as long as you're aware of it, and if you can see that it's a non practicing entity called NPE that owns the IP, that could be a red flag, right? And you can do some digging. What else they own? Have they been in litigation before? So it raises the risk awareness. And you can make your own decisions on whether you want to proceed that route, or is it easy enough to change something where you don't have to worry about it.
Thank you for that. Shabbir, it sounds to me as though you have follow-ups with Andrea, with Sue, with Michelle, with Mark.
Mark, yes.
And those are just the folks who, Dwayne eventually, who came on camera, but I'm sure that after folks view this, there'll be more people to talk with. The thing that I guess scares me most about what you've shared is you're doing quote unquote the right thing, and you're leading with your heart, and this is something can be done and patients deserve and better patient outcomes, but business people don't care about any of that shit. And I'm afraid that.
Well, I just don't believe that's shit, but that's fine.
I chose to be profane for a reason, to say that, if there's money to be made, and
of course,
could it be someone somewhere who's going to look around the margins and say, like, Gordon Gekko says, I wrecked the company because it was wreckable. So, I mean, I know Gordon went to jail at the end, but the point of the story is only after he destroyed a company. So, you know, I'm fond of you personally, and I applaud the effort that you're doing, and everyone who's on the call is like, yeah. And there's just, you know, when you threw out that part about hope, that's where it kind of broke down for me.
Okay. Well, I mean, first of all, thank you. I really appreciate, your giving this exposure and bringing this excellent team of people really to help who I believe will, could very well be instrumental in changing that hope into success. But we understand that this is not some. No illusions. This is going to be tough. As I said, we're essentially in startup mode, but we have we're not like a blank sheet of paper, just an idea. We have data, we have some very good intellectual property. I like to say that, a company like this is like a turtle on a pole. It doesn't get there without help. And so,
a turtle on a pole?
Yeah, a turtle on a pole. It's a Georgia saying. It didn't get there without help.
Okay. Not familiar with it, but all right.
And we need the help.
Yeah, okay. Well, you caught me flat-footed with the turtle on a pole analogy, but Shabbir Bambot, ladies and gentlemen. Shabbir, I'm glad that we could do this today, and I believe that the folks with whom we'll be following up can be helpful.
Okay.
So thank you very much.
Thank you, everybody, and thank you. And again, Happy New Year. Hopefully 2021 is a lot better than 2020.
That's the hope. And next week, Shannon Clark will talk to us about a 2020 recap, how COVID impacts FDA human factors enforcement. Stay tuned. Thanks, everybody. See you next week.
Thank you. Bye.
Bye.